I think many of you know me more from my research hat that I wear in running the clinical trials unit at Bellevue and NYU, but I'm not going to do that today. As you know, I've been doing research with statins and coronary heart disease, and today what I want to do is really speak to you about what I do more often, which is being a clinician and taking care of patients, and hopefully more listen to me than that. But Amy really set me up here about talking about, what we're seeing. And again, from that research perspective is, aging with, HIV itself because of the inflammation, immune activation, the therapies, and then there's something, traditional risk factors. And then Amy didn't mention, but I know was well aware of, is that disease-drug interactions. Not everybody gets abnormal lipids. As she noted, not everybody's getting frail. So what is it about those individuals, maybe with their genes interacting with the disease or with the drugs themselves? Nevertheless, what I want to talk about is something that's been important and on the mind of everyone is healthcare reform. And with healthcare reform, the big key word now has been this optimization of efficiency. So cost effectiveness. So how do we as clinicians then manage our patients when we don't have the answers? Research hasn't told us. Are people prematurely aging? I don't know. I'm seeing these health conditions, but how do I manage that individual that's sitting before me? So I think all this has been gone through pretty well about the increased life expectancy now on antiretrovirals, but again, as Amy noted, life expectancy still is shorter than compared with the general population. Although I do think it's interesting in that cohort series to look that with each 5 years, we're getting closer and closer to approximating the general life expectancy. So what's the impact of this increased life expectancy on the comorbidity prevalence? And then that impact has really changed when we're starting to recommend when we should begin treatment. And as Amy mentioned somewhat, the appropriateness of the primary care guidelines. And again, today I want to speak to you on behalf of me as a clinician and also as my role for New York State AIDS Institute as a member of that primary care panel, and I'm also the chair of the national panel for the primary care guidelines. So how should we take all of this in the context of how we're delivering care? So antiretroviral therapy may produce these chronic adverse effects as we've heard about. But just as, years ago I was called Chicken Little because I said, like the sky is falling. I said, people's lipids are up and we're going to see coronary heart disease. Well, I would come back and say, what is it about HIV? You think HIV somehow won't protect you from developing coronary heart disease? Well, I hear the same thing now with cancers. Why is it that somebody would even begin to think that individuals with HIV are not at the same risk or even increased risk compared to the general population for things like cancers? And then we are seeing some conditions at an earlier age. Age disproportionately affects care resources, and Dr. Freed talked about this quite a bit. About 80% have at least one chronic disease, right? And these are the most common conditions here, the arthritis, hypertension. It's interesting what Steve just showed us about hearing loss, because lots of times, again, we think about premature aging and we say, well, we're not really seeing vision loss at an earlier age or hearing loss at a younger age. But as you were showing that slide, I was saying to myself, have we really asked that question? When the patients come in, do you really ask your patient, hey, you notice your hearing's decreased? So some of it may be what we do in the exam rooms of what we're addressing or not addressing. And the elderly make up only 13% of the population, but as we saw earlier, they utilize a lot of care resources, particularly prescription drugs, over-the-counter meds, etc. And then we're seeing, too, that the elderly actually suffer 2 to 3 times the rate of adverse drug reactions. So I want to look at something called payoff times. And sometimes these things kind of annoy me. I'm not a modeler, but that's how we kind of look at things sometimes, and we model these, and that's how we develop guidelines. But a payoff time is the minimal time until incremental benefits are greater than the incremental harms. So it applies to any of the guidelines where the harms are really short-term and benefits are long-term. So let's talk about colorectal cancer screening. I'm over 50. I had to get a colonoscopy because that's one of the recommendations. That's when we're at risk for getting colon cancer, and maybe you can catch it early enough. That varies, though, by guideline and by patient population. And I could say one time I started getting cancer screening at 40 because my mother died by age 52 of colon cancer. So you have to take what a recommendation is and modify it for that individual. So a payoff time can be compared to what the life expectancy is. So if death is likely before payoff time, then the guideline's not advised. But if death is unlikely to happen before the payoff time, then the guideline would be advised. So let's take this case. This is a 60-year-old gentleman with HIV. He's on salvage therapies. He has a CD4 count of 46. He has severe chronic obstructive pulmonary disease and hepatitis C. So his payoff time for case 1 is 7.3 years. His life expectancy is 5.1 years. Therefore, because his life expectancy is less than the payoff time, it's the minimum time until that benefit, right, exceeds the harms. Case 1 is unlikely to benefit from colorectal cancer screening, so you would say you don't offer this to your patient because odds are this gentleman's going to die from his underlying disease long before he would get any benefit from something you would find by colon cancer screening. Whereas case 2, a 60-year-old HIV-infected female on first-line antiretrovirals who has a T-cell count of 392, and her only underlying comorbidity is diabetes, her payoff time for case 2 is 5.7 years, but her life expectancy is 15.1 years. So therefore, she would benefit from colorectal screening. But what I'm going to do is I'm going to challenge this because I'm going to say, what if we don't really have the right assumptions, right? Because when you look at payoff times, you have to make sure that you've taken that assumption the right way. And just when you look at some of the other models about when to start hard and things like that, there's assumptions that somebody on salvage therapy, T-cells aren't going to really climb, that they're going to fail again, they're going to have resistance. But we're seeing as we have new medicines that people's life expectancies are in fact improving. So with that, just that basic assumption that because somebody's on salvage therapy or has a lower CD4 count, does that mean that we shouldn't do that? If you go back in time, we used to not offer hepatitis B vaccination to individuals with HIV because we said, oh, you have HIV, you didn't already get hepatitis B, and your chances are that if you got hepatitis B, you would die from HIV long before you get the benefit of hepatitis B vaccination. Well, what happened? We had a group of people that didn't get vaccinations, and now they have hepatitis B that's really a problem for them. So, again, you got to think about what those assumptions are. So, although some people say, well, colorectal screening then may not always be appropriate in the settings of low CD4 count and salvage therapies, I think we got to really think about those assumptions. So just another reason to think about these is because Ed Binney, who's at the VA in Manhattan, did a study, and what he did is he looked at individuals with HIV and not HIV, 50 years old or older, and did the routine colorectal screening. And what did he find? He found that there was more lesions among those with HIV, that the stage of disease was greater, and that the lesions actually were more proximal, so higher up in the colon. What does that mean? Well, it means that some places use what's called a flex sig, so they just look at the lower end, right, of the colon. They might miss lesions in HIV if that's the type of screening they use for colorectal cancer. So you need to do full colonoscopies. It also suggests that maybe HIV itself is a risk factor for colon cancer, and maybe the screening needs to start at age 40. So the whole thing with that whole original model is really of what age does screening begin. And as Amy mentioned then, maybe HIV itself is a risk for other diseases and it needs to be incorporated